you very much for the opportunity to be here. I will actually do a little promo here just briefly. It's called The Last Great Race. We've been following this for about 20 years, and I could spend all hour talking about it. The other thing that we're interested in is curling, so we kind of have a lot of sports. But I am a UNC basketball fan, so that kind of makes me okay. I do want to say it's interesting, it's already been mentioned that we've had almost 72,000 deaths in 2017 from all drug overdoses, and about 2/3 of those, or 48,000, 50,000, are from opioids. But I do want to say it's interesting how you're going to hear a lot, not a lot, but some of my faith story in this. I remember, some of you may know, I've been associated with the North Carolina Caring Dental Professionals, which is basically the equivalent of your PhD in medicine. I've been associated with them for almost 25 years. And one of the things in the secular world, as we say, it's hard to sometimes live your faith out. And in the last few years, I've been praying that God would use me in a way that I could actually talk about my faith in light of recovery and addiction and drug problem. And it's interesting how Bert came into my life a couple of years ago, so God has a plan, and I'm going to kind of share some of my thoughts and stuff in light of the opioid epidemic. I'm going to just start out with some brief information, not to insult your intelligence, but just sort of tell you where we're coming from. I always get the question, especially my dentists, what's the difference between an opiate and an opioid? Well, we think of the natural opiates as the poppy seed, or the poppy plant, if you will, the morphine, codeine, thebaine derivatives that we get out of that. And then in our world, especially dentistry and medicine too, we know the semi-synthetics. And I just will say one thing about advertising and marketing. One of the reasons, as Dr. Fowler said, that 99.7% of the world's consumption of hydrocodone is in the United States, is it's from this marketing of hydrocodone that this occurred. When it was first started, hydrocodone was Vicodin, and we talked about VI, that's 6 times stronger than codeine. That's the way it was marketed. Whether it was, I don't know. But when I came out of Chapel Hill in 1980, dental school, I had Tylenol 3 and 4 and Percocet. There was nothing in between. Thank goodness for Vicodin, right? We needed something for moderately severe pain. And then oxycodone was marketed as 12 times stronger. Oxy does not mean 12, but that's sort of where the marketing went. And then, of course, what's really fueling and making this whole opioid epidemic gain traction and actually destroy the heart and soul of this nation are the fentanyl and its derivatives, and we'll talk more and more about that. This is just a summary chart looking over the last 3 or 4 years of the total number of deaths. We're looking at total number of all overdose drug deaths, about 52,000. And then of those, opioids were about 34 back in 2015. And some of the projections of the CDC and others say this is going to get worse, and we're actually seeing evidence of that. Estimated that 2021 will be 90-60. One of the things we're seeing here in North Carolina, and I'm sure it's going to be probably coming along statewide or nationally too, is that we've always used this term that 2/3 of all overdose deaths come from opioids. Well, we're seeing some evidence now that number may be going up, maybe as high as 75 to 80%, and mainly driven by fentanyl and its analogs. So we'll touch more on that as we go on. Again, the U.S. does consume 80% of all the opioids in the world. And it's kind of interesting that we do have to have a pill for everything. I remember having a conversation with a daughter one time. She was having a headache, and she says, "I need a Motrin." And I said, "Okay, but your body is not deficient in ibuprofen, right?" And she goes, "Yeah." I said, "What's causing your headache?" And the response I got from a teenager, "Oh, Dad," that thing. But she needed to go there. My son, when he was little, I had a stomach ache one day on a Saturday morning walking around the house, and he said, "What's wrong?" I said, "My stomach's upset." He said, "Take the purple pill." I said, "What's the purple pill?" I didn't know what a purple pill was. Watching TV next to him, of course. But these are some stats here. This is going to be kind of a fast-paced presentation because I like to get a lot of information out and kind of get you thinking. These are the percentages already mentioned of the consumption the U.S. Consumes, the 99.7%, and then the other percentages there. I do want to talk a little bit about some issues that deal with are these medications coming? I mean, where's the heroin coming from in the United States? Because there seems to be a big confusion about where it's coming from. We know that 87% of all heroin is produced in Afghanistan, but most of the heroin that comes into this country comes from Mexico and Colombia, and we'll talk more about that. Mexico, a lot of, like 98% of all fentanyl is synthesized in China, and it's brought over to Mexico and Canada, but mainly Mexico, and then it comes across the border in various forms. But we do know that most of our heroin that comes in this country is not from Afghanistan, it's from Mexico and Colombia. It's where they're grown. This is kind of a detailed graph, but I'll just show you that in looking at between 2006 and 2017. And this is from the North Carolina Injury and Violence Prevention Branch. I do some speaking for the Governor's Institute on Substance Abuse, and this is one of their latest data charts that they have. And it shows that in 2006, about 2/3 of all the deaths in North Carolina, drug deaths, were from opioids. But in 2017, that number is almost 77%. So we're actually seeing a rise in the amount of opioid deaths. When you also look at, and this is actually from the medical examiner's report, but this shows that gradual trend of it going up there from 2006 to 17. If you also look at the heroin, and again, when your patient, or when you talk about heroin, there's no such thing in my mind as pure heroin. Anytime you say heroin, you assume it has fentanyl in it or other additives. It's hard, the heroin of the day back in the 70s is not the heroin that we're talking about today. This is, cut with different things. A kilo of heroin costs about $60,000. A kilo of fentanyl is about $2,500 to fabricate. And usually out of a $2,500 kilo of fentanyl, a good drug dealer could make upwards of $1 million, $1.5 million just mixing it with other drugs. So it's a good drug to cut with. But heroin, as you see here in North Carolina from 2010 to 2017, you see an increase, but in the last 2 years, we've seen a little bit of a decrease in the number of deaths associated with what they're calling involving heroin. So I'm sure some of that may be with other things too, like fentanyl and stuff. Duke University just released this recently, showing the 4 areas of our state that are really affected over the last 17 years about heroin deaths. We're looking at Gaston County, which is right next to where I'm from in Shelby, Cleveland County, Vance County, and then of course New Hanover, and Brunswick counties. And I think this is interesting to look at because this is where a lot of the activity of overdose deaths occur and activity of drug use occurs. Carfentanil, I'll mention that. Some of you are familiar with that, I'm sure, being the elephant or tiger tranquilizing drug that the vets use to, kind of bring down the big animals to work on. Well, carfentanil, as you know, is very, very powerful, and this is really what's one of the fentanyl analogs that's killing people. In June of 2016, the Canadian Border Patrol stopped a truck that had 1 kilo. It was in a little plastic container that had ink for a printer. He took the ink out, put it in one of those little plastic containers. They went through the truck and found a kilo of fentanyl. That was enough fentanyl to actually kill 50 million people, which is about the size of Canada as far as population. In September of 2017, another truck was stopped by the Canadian, not Mexico, but the Canadian Border Patrol, had 42 kilograms of this stuff in there, enough to kill 1/3 of the world's population. Now you may say, why is he talking about killing people with these drugs? Well, the fact of the matter is, this has already been tried several times before. The most notable one was in Russia when the Chechen rebels took over the theater, 2005, 2006. They sprayed through the air vents one of these drugs. This is part of the drug they put in the air, and it killed not only the rebels, but also some of their own men. So it's a very, very powerful drug, as you know. Policemen, dogs that sniff this stuff out, they are actually dying, falling over, having to be reversed with naloxone when they do these drug busts, or when they go into houses or warehouses looking for this stuff. So the animals are being affected too. In the United States, up to date, this is pretty recent, we have about 70 identified analogs of fentanyl, and in North Carolina, the latest report I saw said we had identified about 44 of those analogs here. The one that's really gaining traction right now is acetylfentanyl, which is the one that's really making the news up in Asheville. That Buncombe County's really interesting place. As you probably know, the western North Carolina has a lot of overdoses with that neonatal opioid withdrawal syndrome. I mean, they have a lot of kids being born in that area. We had an employee that was one of our dental assistants whose sister was waiting to adopt a baby. It was a pair of twins that were going to be born, and she was going to take one of the twins. And this was just a couple years ago, and the mother was in recovery. She was a heroin addict. It was on Saturday night, and they found her with the needle in her arm. Both babies died. She survived, and now she's going through the court systems of, having to deal with the consequences of that. So it's a very, very powerful, she was in Asheville, but it's a very, very powerful drug, and it's one that you're going to hear more about. Now, I'm going to switch gears here because I'm going to talk about pain just a minute. Now, in dentistry, I call dentistry the 72-hour profession. In our profession, how many dentists do we have in the room? Okay, so in our profession, you can attest to that if you treat a patient for a dental pain, within 72 hours, they should be better. If they're not, we're going to see them again. Example, a dry socket from a wisdom tooth extraction, a crown that's too high that causes constant pain. There are things that we can do to adjust that. In medicine, I understand that you guys are dealing with more chronic pain, more very, very difficult people. A lot of times polypharmacy involved in that. It's just not pain medicine. And of course in dental school, this is about all I remember from pain. It was, if it's acute pain, it's less than 3 to 6 months, and if it's chronic pain, it's over 6 months. Some dentists do deal with chronic pain. I mean, the TMJ, chronic facial syndromes and stuff, but that's rare. It's not many of us. But I do want to talk about pain and maybe how we got into this situation with the opioids. There are types of pains, different types of pain. The nociceptive pain that we know as the pinprick or the toothache. I mean, patients come to us and they say, I'm hurting, I want you to do a root canal, take the tooth out, but I want to stop right now. I want it to end. Take care of that pain. We also have pain that's associated with neuropathic pain, as you guys know, from MS to other chronic illnesses. And then we have another pain that sort of is very important in the development of this opioid crisis, and the central sensitization pain, which deals with the development and maintenance of chronic pain. And a lot of you guys, I know, deal with patients who have that. An interesting aside here, in December of last year, just a few months ago, a representative, and some of you may know this, but a representative from the North Carolina Medical Board reported that of the 26,000 physicians, licensed physicians in North Carolina, 17,000 of them are violating the STOP Act by prescribing too many opioids for too longer periods of time. And it said that the physicians were going to be getting letters to that effect. I don't know if anybody affects anybody in the room. Don't raise your hand, as Dr. Horn said, don't raise your hand. But I'm just saying that I feel for you guys because it's a different world than we live in. So I just bring that to your attention that it's on the radar that they're looking at what we're prescribing. And then the last thing is the opioid withdrawal pain. We talk about, withdrawing from benzos or alcohol. We worry about seizures and DTs and all that kind of stuff. But with opioids, for the most part, the old saying is you're not going to die during the withdrawal. You just want to. You feel that bad. But opioid withdrawal pain is very real. And I will say that when you think of the drug addict or the person addicted to drugs, that you think of, living under the street, under the bridge or on the street or in a cardboard box, that's not the drug addict of today. The drug addict of today can be a 62-year-old female mom with grandkids. Most of the deaths occur between that 45 and 55-year age. It's not the young people as much dying as that middle-age section because they're a lot of times on different, pharmacies. They're taking a lot of other drugs, and But it's quite interesting. The opioid withdrawal pain, I want you to think that possibly a lot of 30-40% of the people that are using drugs today, chronically, every day, they're not getting high anymore. They're just trying to stop from going into withdrawal. The pain is so great. And I equate it to, it's not the same, but you kind of get a little feel for it, that if you are trying to cut back your eating, and you say, I'm going to go on a diet, and you say, I've got this, and day 1 comes up, and day 2 comes up, and you're on day 3, you're eating ice cream again. That pull, that pull to go back, that pleasure center wants that food, that pleasure. It's the same kind of thing, but in a different way. It's a lot more powerful. I will say, Dr. Horn mentioned, one of my favorite things when we do counseling for people who are addicted, I like to ask the family, what is your drug of choice? And they look at me like, what are you talking about? So I'll ask the addict, I'll say, what's your drug of choice? And they'll say, alcohol. And I'll ask the family, so what is your drug of choice? And they don't know what I'm saying. Well, their drug of choice is the addict. Because if the addict's having a good day, he got up and he went to work, and things are good, he didn't hit the kids this morning, the family's having a great day. And then they get a call that night, he's back at the bar, they're having a bad day. So it's this dynamic, ever-changing dynamic environment. So types of pain. Now, I'm not gonna preach, I promise, even though it's dangerous to give me a mic. Who has anyone ever heard of Austin Eubanks? Austin Eubanks, Eubanks. Austin Eubanks, he does a TED Talk that you can go home and watch it. I highly recommend you watch it because this is what we're talking about. Austin Eubanks in 1999 was laying on top of his best friend Corey underneath the table in a library in Columbine, at Columbine High School. And I heard Corey 3 times last year speak, and he's actually speaking at the ADA in a few months. But I heard him speak, and he said that, I heard the 911 call, and the teacher was yelling out, get under the table, they're coming back in to shoot. And the shooters were coming back in, and they were shooting people just to make sure they were dead. Corey got shot in the foot, and he got shot in the arm. No lasting effects from it. Corey's fine now. Corey's probably, this is not Corey, by the way, but he does sort of look like him. Corey's about 37 now. But anyway, Corey said that when he was taken away from the scene, that he went to the EMS vehicle, and medics were coming up, and one of the questions they asked, are you in pain? And he said, not really. He said, you've got to be in pain. I mean, you've been shot. He goes, well, I mean, it hurts a little bit. He said, my pain's right here. He started pointing to his heart. So they gave him some opioids. And then they took him to the emergency room, and the doctors asked him, good intentioned doctors and nurses, are you in pain? And he says, not really, I'm just traumatized. And he goes, okay, so they gave him opioids. Anyway, his story goes on that over a period of time that he got addicted to opioids. And he is now opioid free. He's been in recovery for a while. But he tells a story about how opioids are not what he thought they were. He thought they were excellent painkillers. He said they did very little for his pain. He says, in fact, the physical pain part that opioids takes care of, other than making you a little loopy or kind of high, is okay. Maybe studies have shown 20 to 30% of the patients really talk about this is a really effective painkiller. He said the thing, though, that it was excellent. He said it was the best antidepressant he's ever had. And he said for emotional pain, it made my life come into focus. He said, think of being at the eye doctor and everything's blurry. He's going 1 or 2, and you say 2 when it comes into focus. He said that's what opioids did. It made me feel normal, and that's the term. So I want you to remember and just assume if Corey's right, if Austin is right, that emotional pain is treated better with opioids than physical pain. Now let's just assume that's right. I'm kind of a skeptic at a lot of times, so I started looking at some of the evidence to see if any of that made sense. Well, the CDC says every day, this was in 2016, so it's a little old, it's probably higher now. Every day in America, over 1,000 people come to emergency rooms for misusing or abusing opioids. So if we look at the data from 1999 to 2016, which is the period, that 17-year window where most of this research comes from, we found that there's been a 400% increase in the amount of opioids prescribed during that time, along with a 400% increase with the amount of opioid overdose deaths. And we see that reflected just from prescription opioids. But the thing that Americans said during that period of time was their level of pain remained pretty much the same. There wasn't this big increase in pain, actual pain level. And if you include heroin in that, it goes up to 5 times. So, you know, this is sort of what I think of when I hear the word addiction or I hear the word drug abuse. I mean, I like the saying that the two greatest needs of a human being are to be accepted and to matter. People want to be accepted. They want to know they're loved, and they want to make a difference in the world. And I used to always say that, you know, this being a heart with a hole in it, that America has a hole in their heart, and they're looking for something to fill it with, to make them feel normal, to come back into focus. You know, what they're really looking for is a savior, but they don't know that. They think it's in the form of a pill or internet or whatever it is. So this is a very powerful image, and I want you to kind of remember that as we go on. So if we look at acute pain, this is the thing that Corey really brought up. I keep calling him Corey. That's his friend that died. Austin brought to light. He says, you know, that my trauma was not with where I got shot. The trauma was inside. So let's think about acute pain. And I know all you guys know this, but I'd just like to talk about it a little bit. When someone comes to me with a toothache or comes to you with a joint that's hurting or whatever, they're focused on that pain. They're thinking, this really hurts. Doctor, I want you to fix it and make it go better. Most of their attention is really focused at the tissue level. They're not thinking, you know, am I going to be able to go to my grandson's soccer game in 3 weeks in Raleigh? They're not thinking, we're going to have to miss that vacation in 2 months. They're not thinking about that. They're thinking about, it just hurts, just take care of it. On the other side, when you have people who have chronic pain, it's kind of the reverse. Their thoughts and emotions are engulfed in their life. If you take a person with MS and you say, and they have spasticity or whatever it happens to be, talking about spasticity with CBD or marijuana or whatever, but anyway, they have spasticity in their legs and arms and stuff. Yeah, I mean, if you touch it and say, does that hurt? They're going to say, yeah, but they're not focused on that. They're thinking, you know, am I going to be able to walk in a year? Am I going to be in this wheelchair? When does the wheelchair come? Or will I be here next year? Maybe you have some kind of terminal, Alzheimer's or something. People are engulfed in that. So unfortunately, over time, we've treated chronic pain with opioids. And this is sort of one of the things that's kind of gotten us into this problem where we think that we need to give something for pain. I'm not saying there aren't times that you have to, but I'm just saying that this is sort of the way I look at acute and chronic pain. Some of you may have seen this where it says people who are addicted to alcohol are twice as likely to be addicted to heroin, 3 times marijuana, 15 cocaine, but opioids, a person addicted to opioids, prescription opioids, are 40 times more likely to be addicted to heroin. In fact, studies, one of them done by SAMHSA and also by ASAM, the Addiction Society,